a recap of histology. So although I'm sure everybody knows it, and how the pattern-based or the algorithmic approach works. And then we'll go into the cases. And when we talk about bullous lesions, and I'll also be talking a little bit in detail about immunofluorescence. So I hope that is okay with everyone. So to begin with, we know that the skin is the largest organ in the body, and it has two parts, the epidermis and the dermis. The subcutis, technically not a part of the skin, but nevertheless, it's sampled in the biopsy, so we see it all the time. So there are different structures that we see in the skin. And in the epidermis, the cells that we encounter, all of us know, are the keratinocytes, melanocytes, Langerhans cells, and Merkel cells. This is the structure of the epidermis. From top to bottom, we see the stratum corneum, the stratum granulosum, the stratum spinosum, and the stratum basale. And you have the melanocytes that are interspersed in between the basal keratinocytes. Now, the dermoepithelial interface. Now, notice that I don't use the word dermoepidermal because it's a dermoepithelial interface, because it goes around all the adnexal structures, the vasculature, as well as the Schwann cells of the nerves, right? So this is a highly specialized structure. And this is the structure that, all of us, we look at textbooks and, we know that this is what is important for us, especially when we are dealing with bullous lesions. So what is important for us? That is what is in between the keratinocytes, that is your desmocollins, desmoglines, the desmosomes, which are important in pemphigus, and the hemidesmosome, which plays an important role in pemphigoid. So we'll understand more about this when we talk about blistering diseases and immunofluorescence. Now coming to the dermis, you have cells, you have collagen, you have adnexal structures, and then you have the nerves, blood vessels, lymph vessels, and smooth muscle. And we know that any of these structures could be affected in inflammatory dermatitis. So this is the structure of the sebaceous lobule. You see the mature sebocytes in the center, which are multivacuolated with a central scallop nucleus and the layer of the germinative sebocytes at the periphery. And that's the sebaceous duct, which is recognizable by the crenated outline. The apocrine and ecrine units are told apart only by the secretory portion, where you can see the decapitation secretion in case of apocrine units, whereas that is absent in ecrine units. Instead, you may see pale to clear cells. If you look at the ductal and the acrosyringeal part, both of them look pretty similar, except where they open into. The ecrine ducts open straight into the epidermis, whereas the apocrine units open into the folliculo-sebaceous units. The hair follicle is a very complex structure, so I am not going to be dealing with diseases of the follicle today because that's a whole slide seminar in itself. But let's understand what are the parts of the hair follicle from bottom to top. We have the bulb, the stem, the length of which is variable, the isthmus, and the infundibulum. So these are the parts of the hair follicle. And if you look at the bulb, you have the papilla, the mesenchymal papilla containing the vessels, which is forming this cup-shaped invagination. Then you have the dendritic melanocytes, which impart color. Then you have the matrical and supramatrical cells, which form the follicular germ, which give rise to the hair shaft. And then you have the inner and outer root sheaths. The vasculature is perhaps the most important structure in inflammatory diseases. You have the superficial vascular plexus as well as the deep vascular plexus. So the superficial vascular plexus, which is located in the papillary dermis, and the deep vascular plexus, which is at the junction of the dermis and subcutis. And this has a lot of significance when you're trying to take a biopsy for diseases which affect the blood vessels. And the subcutis, of course, you have the lobules and you have the septum. Now, commonly, these are the types of biopsies that we receive. So most commonly for inflammatory diseases, we receive punch biopsies. Shave wedge biopsies, we don't receive so often. Incision biopsies are sometimes done for blistering diseases, and excision biopsies is usually done for tumors. So we don't encounter that so much in inflammatory conditions. Okay. This is very important. Even if we cannot be experts in clinical dermatology, we have to be conversant with the basic terminology and clinical appearances, because uh, to a dermatopathologist, clinical dermatology is gross pathology. The way we give emphasis to gross appearances in other lesions, so this is what you should be knowing. So in the interest of time, I cannot describe in detail all the clinical appearances of the lesions. I will refer to a few of them as and when we discuss the cases, but we should be conversant with the definitions and terminologies which are used by the dermatologists. Now, having said this, what exactly is an inflammatory skin disease? So basically, these are diseases which are characterized by a significant infiltrate of inflammatory cells on histopathology, which may be associated with secondary changes, but not associated with any other pathologic processes. For example, you can have a significant amount of inflammatory infiltrate in diseases like Bowen's disease or actinic keratosis. That doesn't make it an inflammatory skin disease. So, having known the definition, now there are a lot of ways of classifying inflammatory skin diseases. But perhaps the most popular approach, and the one which works almost every time, is the algorithmic approach, which was pioneered by Dr. Bernie Ackerman. So this is what we are going to be using today. And in this approach, in fact, Dr. Ackerman refined this approach. So the last book that he wrote shortly before his death was in 2005. So according to this, there are 7+1 patterns, right? So 7 patterns which belong to the skin and 1 pattern which belongs to the subcutis. And contrary to the approach which starts with defining the epidermal changes first, this approach uses a dermis first approach. So you're trying to first define what is the dermal pattern and then look at the epidermal changes. And there are certain advantages and disadvantages with this method. So we will look at that as we go more into the details. So basically, there are 3 steps. First of all is to identify the pattern on scanning magnification. And it is very helpful if one has a 2x scanner, a 1x or a 2x scanner, which would give you a very accurate description or an idea of the pattern. Now, what are the patterns? There are 7+1 patterns. You have perivascular dermatitis, which is nothing but the presence of infiltrate around the blood vessels. Then it could be either only perivascular, or it could be perivascular and interstitial. So the interstitial pattern is something which is in the background. Our eye is not trained very well to pick up an interstitial or an infiltrate in the background. So that's the reason why we have to keep this in mind. Then comes the nodular dermatitis, which is nothing but an exaggerated perivascular dermatitis where the infiltrate appears in nodules. And most of your granulomatous skin diseases come in this category. The nodules could be comprising of only lymphocytes, histiocytes, neutrophils, as you see in suppurative inflammations, or it could be a mixture of all the infiltrates. So there are different patterns in nodular dermatitis, in granulomas to be specific. They could be tuberculoid, they could be naked or sarcoidal with a paucity of lymphocytes. They could be palisading, that is, there's something at the center and the histiocytes are fencing it. And finally, you have the mixed or the suppurative patterns. Coming to diffuse dermatitis, this is nothing but a coalescence of nodules. So you don't have space in between. So the entire dermis is involved by the infiltrate. Then comes the vasculitis. You have 2 patterns in vasculitis. You have a small vessel and a medium vessel vasculitis, which are different. Then you have the vesicular dermatitis or the blistering diseases or the bullous diseases. Then you have the pustular dermatitis, which is nothing but you have vesiculation that are filled with pus or neutrophils. Peri-infundibulitis and folliculitis is the next pattern. If you look at this slide, you can see that the infiltrate is centered on the follicles at varying depths. And most of the alopecias come in this category. This is followed by the fibrosing dermatitis, which is characterized by extensive fibrosis or sclerosis of the dermis. The last pattern is that of the paniculus, that is paniculitis. The second step is to identify the subpatterns. For example, if you take perivascular dermatitis, it is associated with a host of changes, especially in the epidermis, in the form of interface, ballooning, spongiotic, psoriasiform, or sometimes there are no epidermal changes. So these are some of the sub-patterns which we will identify as we go into the cases. In the cases of vesicular dermatitis, all of us know that we classify them as intra and subepidermal. And sometimes when there is reepithelialization, you happen to see both the patterns in a single biopsy. And of course, composition of the infiltrate is important in certain conditions, and we all know what are all the cells which can come in the dermal infiltrate. Now, the last and most important step is to integrate with clinical information. There are several conditions in which the pathologist can only give the pattern. Reaching the final diagnosis depends on integration with clinical information, performance of additional tests such as ancillary tests, it could be special stains, it could be immunofluorescence, and many a time even follow-up. So sometimes you have to follow up the patients for months together and then you know what the diagnosis was. So the final diagnosis or the final or the most critical step, cliched as it may sound, is clinicopathologic correlation, especially important in inflammatory diseases. Now, what are the limitations of this approach? You can get a mixture of patterns. For example, you could get a spongiotic and a psoriasiform pattern. You could get a psoriasiform and a lichenoid pattern. So we should know what are the diseases which could show these mixture of patterns. The second and more important thing is the temporal changes in lesions or the lives of lesions, or as Dr. Ackerman called them. So lesions evolve over time. For example, if you take urticaria, it's not the same. So if you biopsy the lesion a little later, you will not see any infiltrate around the vessels. So you're likely to sign it out as non-specific, or even vasculitis. It depends on when exactly you're doing the biopsy. So these temporal changes or timing of the biopsy is very important in certain lesions. Now, superimposition of artifactual changes. So effect of itching, rubbing, lichenification, etc. can confound the original diagnosis. So, and this is something which we have to keep in mind. And of course, where necessary, we need to resort to ancillary tests. So to summarize, try to identify the pattern, identify the sub-pattern, the nature of the infiltrate, make a short list of the differential diagnosis. And what I do is I do this and then look at the clinical details. I don't bias myself looking at the clinical details before I sort of get an idea. So that's a good way to have a CPC. And please don't hesitate to ask for pictures, ask for additional information. And it's very, very important to have an open and healthy dialogue with your dermatologist so that both of you are on the same page, that you know what they mean and they know what you mean. So I think that's most important before we interpret skin biopsies. So I think I will stop at this with the introduction. So can we start with case number 1? So this was a 42-year-old woman with erythematous scaly plaques over both legs. So can I invite Dr. Ishita to take this case?
Okay. Yes, ma'am. This is an H&E stain section of skin, which is showing an regular elongated retty ridges, and in the regular elongated retty ridges in the dermal papilla, and the we can see. We can see that blood vessels are dilated in between the papillae, and there's alternating retty ridges so that the epidermis is thinned out at places, and in the dermis we can see mild to moderate inflammation.
Dr. Ishita, can you tell me what pattern this fits into on scanning magnification? Because that's the first thing that we're supposed to start with. What pattern would this fit into? Look at the dermal infiltrate. What is the pattern you're seeing here? I hope you all can see my arrow. Can you see my pointer? Is my pointer visible?
Yes, ma'am.
Okay. So can you tell me what pattern this would fit into? Because we looked at so many 7+1 patterns.
This is psoriasis form.
No, we're talking about the dermal pattern, Dr. Ishita. We've not yet gone to the epidermis. We're talking about the dermal infiltrate. I'm delineating it for you. Can you tell me what pattern this is? Where do you think the infiltrate is?
Perivascular.
Yes, you're right. So it is a perivascular pattern. So the broad pattern is perivascular. And then we come to whether there are epidermal changes or not. So like you rightly said, there are epidermal changes. And what is the epidermal change here?
Elongation of retinages.
Yes.
And we can see the vessels in between the ridges are dilated.
Okay. So when we talk about elongation of rete pegs or rete ridges, so is there anything else that you notice about them? Are they all more or less of the same length or they are
Same,
different?
yeah.
Different?
Yes, most of them are almost in the same length.
Yeah. So what is the term you would like to use to describe this? You can call this as even regular psoriasiform acanthosis, right? Yes, right. You're right.
Yes.
Okay. Then, so you described all the findings. So now, after having described the pattern, can we look at what's happening in the stratum corneum? Are there some clues here?
With the hyperkeratosis.
What is the pattern of the stratum corneum? We have to start with that. Start from the stratum corneum and then go downwards. What is the pattern of keratinization that you see?
There's a little hyperkeratosis.
Yeah, so there
And the
is.
granulosum
Yeah,
is
so normally it
reduced.
would be basket weave orthokeratosis, but here you see the keratin is very compact and pink, right?
Yes, ma'am.
So this is orthohyperkeratosis. And there's something else here. Can you make out what
Stratum
this is?
granulosum is thinned out.
Sorry, can you repeat that, please? Your voice is breaking.
Stratum granulosum is very minimal. We cannot see it.
This cluster of this, I'm pointing to this structure or this feature.
This one.
There seem to be some nuclei, isn't it, in the stratum corneum? Yes. So there is parakeratosis and there are also some other cells. There are some inflammatory cells. There are a few neutrophils in that. So what would you call that? So this is what we refer to clinically as a scale crust. Parakeratosis is scale and neutrophil is crust. So this is a scale crust. So how is this scale crust distributed? It's very discrete. There's one here, there's one here at a different level. And if you go to the other tissue bit, you'll probably find the same. Okay. Now let's come to the granular layer. What would you like to comment about the granular layer?
Granular layer is almost reduced to absent. We can't see.
What is normal for granular layer? How thick should it be? Dr. Ishita, I'm not able to hear you.
Sorry, ma'am, I don't know.
Okay. So the granular layer normally is about 1 to 3 cell thick, right? So here, if you notice, you hardly see the granular layer.
Yes, ma'am.
Right? So it is not there. So it is diminished granular layer. Okay?
Yes.
Then, is there anything else that you see in the epidermis? What are these areas? How would you describe this change?
There is spongiosis there.
Yes. So what is spongiosis? Spongiosis is
Basically,
intercellular edema, accumulation of fluid. And the earliest sign is what you're seeing here. The desmosomes appear very prominent. So here you're not seeing vesiculation. So there is very mild spongiosis here. And invariably when there is spongiosis, you will see inflammatory cells, usually lymphocytes. You're seeing a few lymphocytes here.
Yeah.
And this is a little more advanced spongiosis. Right, okay. Now, coming to the dermis, as you rightly said, there are dilated tortuous capillaries, and these are almost, some people call this as the kissing sign. So these are almost kissing the stratum corneum because there is suprapapillary thinning. And do you know what this corresponds to clinically?
Auspit sign.
Yes, very good. So this corresponds to the Auspitz sign clinically. And if you look at the dermal infiltrate, you have only lymphocytes. So you don't see any other cells. You don't see neutrophils or you don't see eosinophils, right? So the other tissue bit also looks pretty much the same. So what is your diagnosis putting all these findings together?
Most like it can be psoriasis.
Yes, so you're very right. So this is a case of classic psoriasis vulgaris. So believe me when I tell you this, in order to find one slide of classic psoriasis, I had to probably go through 20 or 30 slides, which I have signed out as psoriasis. So the reason being that psoriasis is rarely biopsied. That is, classical psoriasis is very rarely biopsied. The moment there is a biopsy, you know there is a problem. So either it's atypical or it is treatment modified or they're thinking of something else, right? So it is not easy to find all these findings together in psoriasis, especially by the time, by the time patients seek help in a tertiary care hospital like ours, they would have tried out some form of treatment, they would have tried topical, systemic, whatever treatments. So you do not have changes in the granular layer, right? The granular layer has returned to normal. The spongiosis has returned to normal. So all that remains is the dilated tortuous blood vessels, right? So that's the most reliable sign to diagnose psoriasis. Now, there are many variants of psoriasis, but the one that we need to be cognizant is pustular psoriasis. Now, pustular psoriasis can occur in patients de novo or it can occur in patients who are known cases of plaque psoriasis. Now, in some instances, you may not have the classical features. If you look at this, there's a subcorneal pustule here. But you look at the stratum corneum, it almost looks normal except for a little bit of parakeratosis here. So it's very difficult to make a diagnosis of pustular psoriasis and to differentiate it from other conditions like pustular drug eruptions. Now, the only telltale sign that you have here is there are a few dilated blood vessels, right? So you may not be able to offer a specific diagnosis in pustular psoriasis because there is an overlap with drug eruptions and also with certain cases of IgA pemphigus for which you may need to do a immunofluorescence. So this is the differential diagnosis of a psoriasiform pattern. So you have to see whether it is psoriasiform only, in which case these would be your list of differentials. Time doesn't permit me to go into each one of them. The next is whether it's a combination of spongiotic and psoriasiform patterns, which occurs most commonly in allergic contact dermatitis and nummular dermatitis, or is it a psoriasiform lichenoid subpattern? So these are the three important subpatterns that we need to think of when it comes to psoriasis. I'd like to ask the chairpersons for their comments before I move on to the next case.
Hi, Uday.
Yeah, I mean, I think Dr. Raj Lakshmi has covered most of the points, but ones which probably would be relevant to students would be that the common sites of psoriasis are on extensors of the body. Like in this particular patient, it was the legs, mostly it's the shins, but it can be the elbow or the knees, or it may be the arm or forearm, back of the arm or forearm, or sometimes the lower back. So that's a common site for plaque type of psoriasis, which gives you this classical appearance. Stable plaque type of psoriasis gives this classical appearance. The other variants of psoriasis may not be as classical, as already told to you by Dr. Raj Lakshmi. Yeah, thank you.
Dr. Poonam, anything?
Yeah, very nicely explained by Dr. Raj Lakshmi. So one thing, because the first year PG students, they must know about the suprapapillary thinning, what different terminologies we are using. And she keep on asking what are the changes in the reti ridges. That is the fusion of two reti ridges. That is also, there is thickening of the reti ridges. So these are the few salient features with which they can go ahead with the diagnosis of psoriasis. So I think that that's all from my side. The basic things about the psoriasis, nicely explained by Dr. Raj Lakshmi. Thank you.
Thank you. So,
Just
thank
to
you,
expand on that, I think
Ishita.
the rete ridges are described as test tube shaped. It is easier for
Yeah,
us to
yeah,
remember. At
Okay.
the
yeah,
bottom
yeah.
is a little bit rounded and
Zero.
broad.
Rounded, yes. Broad based.
Thank you. And thank you, Dr. Ishita, for a very well described slide.
Thank you.
Yeah. So we'll move on to the next case. Dr. Shrija, can you take this one?
Yes,
It's a 22-year-old man with itchy papules on the arm. This is case number 2. Yeah.
yes, ma'am. HND stain section shows epidermis and dermis. In the epidermal layer, yes, ma'am. In the epidermal layer,
Can we start with the dermal pattern? What's the pattern you're seeing in the dermis, and then go to the epidermis?
yes, there is a perivascular infiltrate, ma'am.
Okay, very good.
Perivascular infiltrate, and then uh, the epidermis shows acantholysis, ma'am. Epidermis shows acantholysis, and then there is variable.
Sorry, I did not get that. Can you please repeat that?
There is variable epidermal thickness, and few places there is parakeratosis noted, ma'am.
Okay.
And acantholysis is seen, ma'am.
Where is the acantholysis? Is it in this field, the field that I'm showing you?
Yes.
Okay. What is this here? What has happened here?
Raji, would you like to make a laser pointer out of it? If you click on the right side
Okay.
of your mouse, it becomes, pointer options.
I'm trying that. It's not working.
Just click on the right side.
I did. I'm trying that. It's not working.
It's okay then. Okay.
There is bulla formation, ma'am.
Okay.
And rounded keratinocytes are seen.
Where is it? What is the level? Where is the blister located?
In the epidermis,
Okay, it's intraepidermal. It's within the epidermis. Okay, that's right. Okay, then what else? What is this?
these are rounded keratinocytes, ma'am.
You mean these?
Yes, ma'am.
Okay, but what is this? What is all this pink stuff in the background? There's something pink, isn't it? There's some pinkish material.
Yes.
Okay. Can you do you know what that is? Do you want to take a guess?
I don't.
Okay, fine. Right. Anything else? Any other finding? Would you like to comment on the infiltrate? What is the nature of the infiltrate?
Lymphocytic.
Yeah, so it is predominantly lymphocytic. So you're not seeing too many other cells. Right, okay. So if I could just refine your description a little bit. So as you rightly said, this is a perivascular infiltrate. And if you look at the epidermis, these changes are very focal. Whatever is happening is very focal. If you look at the sides, the stratum corneum is normal, and even the rest of the epidermis is normal. So there is something here which is very focal. And as you rightly said, there is an intraepidermal vesicle formation. And what does the vesicle contain? It does contain a few acantholytic cells, mostly lymphocytes, right? And there are these pink blobs, and it is moved higher up here. Here it is within the stratum corneum, right? So this is nothing but the serum. So this is the spongiotic vesicle, and these are the contents of the vesicle which have moved higher up, because as the lesion is evolving, that's what you see. And like you rightly said, there are a few acantholytic cells and there are lymphocytes. And if you look at the rest of the epidermis, there is spongiosis here also, right? So you have spongiosis of different stages here, starting from early to vesicle formation. And if you come to the epidermis, the dermis, there is dermal edema. There's a lot of dermal edema. And here there are, what do you think these cells are? These are RBCs. And where are they? They are in the interstitium. So these are extravasated red cells that you are seeing here, right? So what would be the overall pattern? What is the overall pattern that you're seeing? Do you want to attempt to make a diagnosis here?
Barrier's disease, ma'am.
Okay, you want to make a diagnosis of Darier's disease. Okay, in Darier's disease, would you find spongiotic vesicles like this?
Ma'am, acute allergic contact dermatitis.
Okay, yes, that is definitely a good thought. So what would we call this? We would call this as a spongiotic dermatitis. And like you rightly said, it is acute because you're seeing that there are not much changes in the stratum corneum. You're still seeing the spongiotic vesicles. You're seeing the parakeratosis with the serum and mostly lymphocytes. And contrary to what we commonly believe, eosinophils are not very necessary for the diagnosis of allergic contact dermatitis.
Yes,
right?
ma'am.
So they may not be there. So it could be just lymphocytes. Now, why is
Yes,
it that I haven't given a specific diagnosis in this case? Because I have not provided the complete clinical information. Now, a specific diagnosis can be made only with clinical correlation, right? Otherwise, there are a lot of spongiotic dermatitis which can look
Yes, ma'am.
similar. Now, whether it's allergic contact dermatitis, whether it's an id reaction, whether it's a nummular eczema, whether it's a pityriasis rosea, so these are all things which require clinical inputs, right? So as a pathologist, what can you say? You can say this is an acute or a subacute spongiotic dermatitis. Now, spongiotic dermatitis evolves. How does it evolve? If it's persistent, it evolves into a spongiotic psoriasiform pattern, or if it goes on for even longer, what do you see? You see this lichenification, right? So this is called as lichen simplex chronicus, in which the spongiosis is very minimal. You don't see spongiosis at all. And this vertical streaks of collagen appear. This is nothing but these are artifactual changes because of the constant rubbing or scratching that happens over these lesions if they are persistent, right? So spongiotic psoriasiform, and psoriasiform. So that's how these lesions evolve. And of course, it depends on the clinical input to reach a specific diagnosis.
Yes.
Now, usually spongiosis is accompanied by lymphocytes. So these are all the differentials that you would think of. But there are certain instances where spongiosis is accompanied by eosinophils, right? So one of the most important diseases where we see this is bullous pemphigoid. And you can also sometimes see this in pemphigus vulgaris. Now, spongiosis with neutrophils, like I showed you previously, you could see it in pustular psoriasis, in pustular drug eruptions, and IgA pemphigus. Right. So I invite the comments of the chairpersons before I move on to the next case.
I think Dr. Rajlakshmi has already covered the 3 stages of the eczema group of disorders. The prototype being, of course, contact allergic dermatitis, but they may be it may be atopic dermatitis, or it may be nummular eczema, or seborrheic dermatitis. So many other types are described. So their histopathology is somewhat indistinguishable. So you require clinical information to correlate to reach specific diagnosis of the eczema. And the 3 stages: acute, characterized by vesicles or edema, and edema in the dermis as well as in the epidermis with spongiosis, and subacute with a combination of hyperplasia of the epidermis and this spongiosis, as well as a bit of parakeratosis and a scale crust, and chronic, which already Dr. Rajlakshmi has shown as lichen simplex chronicus, which is the end stage for most of the eczemas. Thank you.
So I think it is well covered by Dr. Raj Lakshmi and Dr. Uday. So we can move to next case.
Okay, thank you. So case 3, can I ask Jhansi to take this case?
Yes, ma'am.
Jhansi, are you there? Okay.
Yes.
So this is a 43-year-old lady with itchy violaceous plaques on both the legs. Sorry, I think. Okay, just a minute. I think I need to move this. I'm so sorry. I think I've closed that slide. Let me get that back. Dr. Jhansi, can you see it?
Yes, ma'am.
Oh, yeah, so you can start describing.
In the dermis, there is the superficial dermis, there is a lot of inflammation, ma'am. Infiltrate.
What is the pattern? What pattern would you call it?
Lichenoid infiltrate.
Okay, very good. Go on.
Section and it is keratinized Stratford squamous epithelium with bud-shaped hypergranulosis is seen, ma'am.
Okay.
Basal vacuolar degeneration and necrotic keratinocyte.
Okay.
And superficial dermis shows dense band-like infiltrate, predominantly comprising of lymphocytes, ma'am.
Okay.
Reticular dermis shows the fibrocollagenous tissue and the skin adnexum.
Okay, so there are no changes in the deep dermis or in the subcutis, right? Yes. Any negative points that you would like to add? Anything that you're not seeing? Considering that the history is that of an itchy violaceous plaque. So that's the history given, right?
Yes, ma'am.
Yeah. Anything that's important? I think the diagnosis is pretty straightforward. So I'm not worried about that. Yeah. So can you comment on the stratum corneum? Are you seeing any parakeratosis? How would you describe the stratum corneum here? So here you have some basket weave orthokeratosis, right? What is here? What are you seeing here?
Which one? Granular layer is wedge shaped.
No, we're talking about the stratum corneum.
Stratum corneum.
What type of keratinization is this? So this is compact orthokeratosis, right? And you're not seeing any nuclei like you saw in psoriasis, right? So there is no parakeratosis. So otherwise, I think you've described all the findings pretty accurately. So you have a lichenoid infiltrate, and you have this obscuring the dermoepidermal junction at places you're not able to find out. And here there's one feature that I'd like to point out. You don't really see the basal keratinocytes. it looks like the epidermis is directly sitting on the dermis, right? So
Yes,
some
ma'am.
people refer to this as squamatization of the basal layer. So that's one of the features of interface dermatitis.
Yes, ma'am.
Other than that, you have basal vacuolar alteration, you have necrotic keratinocytes, you have this band-like infiltrate, and what is helpful for you is not just the wedge-shaped hypergranulosis you described. What is the shape here of the acanthosis that you're seeing? Can it be likened to something?
Sorry.
Sawtooth
Yes, the
wedge.
sawtooth-like or the irregular acanthosis, right? So what is the diagnosis? I think that's pretty straightforward.
Lichen planus.
So this is a case of lichen planus, right? What cells don't you usually see in lichen planus?
Ma'am?
In typical lichen planus, in the infiltrate?
Neutral.
Eosinophils.
Yes, you're right. So you don't see eosinophils in the infiltrate. So if you start seeing parakeratosis and eosinophils in the infiltrate, you'd have to rule out a lichenoid drug eruption. And lichenoid drug eruption is famous to occur with antitubercular drugs. So that's the point in history that you would have to go back and seek. So I think otherwise you've beautifully described all the features. Now, again, a point about lichen planus is that there are many variants of lichen planus. So again, it depends on what you're looking at. And if you talk about interface dermatitis, there are two sub-patterns rather, that is important. One is the cell poor, or where only the vacuolar changes are prominent. And the second one is cell rich, where you also have a lichenoid infiltrate. And under that, you have to look at whether the epidermis is hyperplastic or the epidermis is atrophic. Now, I've just put an example of a lichen planus that is healed. If you look at it, there's marked atrophy of the epidermis. You have fibrosis of the dermis, and you don't have any infiltrate other than the melanophagus, right?
Yes, ma'am.
So this is the telltale sign that there was a interface dermatitis here at some point. So again, it depends on what kind of a lesion you're looking at, right? So that is about lichen planus, and of course the differential with lichenoid drug eruption. Any comments, please?
I think just the sites of lichen planus as against psoriasis, they are flexor sites. So they are on the flexor aspects of wrists, forearms, and around the ankles, as well as on the dorsa of feet. These are the common sites that are biopsied. But theoretically, lichen planus can occur anywhere on the body, and individual lesions may be present anywhere. Thank you.
It can also occur in the mucosal sites. So so we often get mucosal biopsies for lichen planus.
Yeah, in case of this the lichenoid type of eruption, so one should know about the history, drug history. So what are the common drugs which can lead to this type of changes? Like history is very important, which type of antihypertensive whether patient is taking or not, or beta blockers, or so these history we have to know. So whether patient is on drug or this is actually this is lichen planus. It is not due to drug reaction.
Right. So thank you. We'll move on to the next case, case number 4. Can I ask Bhagyashri to take this case? So this is a 28-year-old lady who developed erythematous plaques and nodules on the face, neck, and arms. And she also complains of a burning sensation on occasion. I did not tell you that the occasion was when she goes out in the daytime, because I thought that history would be too leading, so I held it back from you. Right. So now let's go to the slide.
This is an H&E stain section.
One second. Let me open the thing. Yeah, fine. Okay. Yeah, now you can start describing. Yeah.
This is an H&E stain section shows dermis contains dense periappendigeal, perivascular, and perineural chronic inflammatory cells infiltrate, predominantly lymphocytes, and there also shows focal areas of pigment incontinence in the superficial layer of dermis. And the epidermis is normal looking with no remarkable changes.
So you feel the epidermis looks normal?
Basket weave appearance.
Okay, that's about the stratum corneum, but what about the epidermis?
Yes, ma'am.
I'm showing you something in this field. Can
Ma'am.
you identify what the change is? Can you identify
Only
what's
side.
happening here?
Ma'am, where?
Here, can you see my arrow? Do you think the thickness of the epidermis is normal? Are you able to see the retae everywhere? Are the retae well preserved? I'm just showing you across the entire biopsy. You see well preserved retae. What do you think is happening here? I'm pointing to some areas here. You see this? What is happening here? You can see that here also. So the epidermis, so like you rightly said, the dermal infiltrate is superficial and deep. It's perivascular, periadnexal, and perhaps perineural. So this is around the follicle also that you can make out. And the epidermis does look a little atrophic. It looks thinned out. You're not able to appreciate the retae very well. And this, what you're seeing is extensive basal vacuolar alteration. So that's one of the features of interface dermatitis, right? So there is extensive basal vacuolar alteration. There are not so many necrotic keratinocytes. Perhaps there are occasional ones here and there. But what is striking is the atrophy and the basal vacuolar alteration. So putting these together, would you want to look for anything else in the dermis in the light of the history that's been provided to you? Okay, there's something else happening here. Can you tell me what this is? What structure is this? That's the infundibulum, right? So there's some infundibular plugging here. So there's keratotic plugging of the infundibulum. Okay. Anything else you would want to look for in the dermis? If you tell me, I'll show you. So you have a superficial and deep infiltrate. You have interface changes. You have vacuolar changes. You have a lot of basal vacuolar alteration here. The infiltrate is quite dense. I'm trying to show you something in between the collagen. Do you want to pick up what the finding is? I'm deliberately not showing you the special stain because if I show you the special stain, it'll become very easy. The point is you have to learn to identify it on H&D. What other feature would you want to look for?
Global.
It is there. It is very slight. But you have to learn to appreciate the difference in the shade between the eosin and this. In the interstices of the collagen, what would you like to look for? Look here. Do you see something blue? It looks a little blue. Can you think of what it could be?
Mucin.
Yeah, sorry?
Mucin.
Yes, it is mucin. And what stain can you do to highlight that?
Yes, ma'am.
Alcian.
Yes, you can do an Alcian blue stain.
Alcian blue stain.
Yes, Alcian blue stain. Okay, so if you do an Alcian blue stain, the mucin will be highlighted. In fact, it's all over the reticular dermis. If you go higher and see, it appears as this pale blue stringy substance in between the collagen, right? So what would you like to give a diagnosis on this case? Now that you've got all the findings, the combination of the clinical history, along with the vacuolar alteration, a lot of infiltrate. Do you want to attempt? It's okay, take a guess. Doesn't matter if you're wrong. So this is a case of lupus erythematosus, right? So superficial and deep periadnexal perivascular infiltrates. Sometimes it could be lichenoid. Varying degrees of vacuolar alteration. One of the features we did not see here was thickening of the basement membrane. Probably because this was a little earlier lesion that you're seeing, so we could not appreciate a thickened basement membrane. Lymphocytes, plasma cells often present in the infiltrate. Sometimes you see nuclear dust, and the common denominator is abundant dermal interstitial mucin. So I've got another picture here just to show you how this basement membrane looks. You look at this looks like a caricature, right? So it's a markedly thickened basement membrane, and you have abundant mucin. In fact, you have very little infiltrate in this variant, right? So you could have different permutations and combinations of findings in lupus erythematosus. And lupus erythematosus, again, is a great mimic. It has so many phases like acute, subacute LE, discoid lupus, tumid LE, lupus paniculitis, also called as lupus profundus, and alopecia of lupus erythematosus. So it figures almost in every pattern. Although characteristically we describe it in the interface dermatitis, it can mimic a lot of, and you have bullous LE also. I forgot to mention about bullous LE. So it can mimic a lot of the patterns that you're looking at. So the index of suspicion has to be high, and you need the clinical inputs in order to suspect lupus erythematosus. And of course, a direct immunofluorescence, if it is done, would help you in supporting the diagnosis. I won't say it's diagnostic. It helps you to support your diagnosis. So that was a case of lupus erythematosus. Any comments on this?
I'll just mention about the sites of lupus erythematosus lesion that you showed. That was the chronic cutaneous lupus erythematosus. So those lesions usually occur on sun-exposed areas like the face, scalp, ears, sides of the neck, or V of the neck. More than that, if it occurs below that, then we call it disseminated discoid LE. And then the chance of such a patient having systemic lupus erythematosus increases. Otherwise, the chronic cutaneous LE patients may have less chance of developing systemic lupus erythematosus. Thank you.
Already explained all things nicely. So students should know what is the cutaneous lupus erythematosus and what is generalized, whether it is systemic or cutaneous. So detailed clinical history is very important, and different types of cutaneous lupus erythematosus is already explained by Dr. Raj Lakshmi and Dr. Uday. So you can go ahead. So there is importance of IF in these cases also.
So just by looking at histopathology, it's not possible to say whether this patient is going to have systemic lupus erythematosus or not. So the bottom line is you need to have the clinical information and other autoantibody profiles and things like that. So I think that's the take-home message that all of you need to understand. Okay, we'll move on to case 5. So is Dr. Mailung here? Mailung, are you there? Can you take this case? It's a 10-year-old boy with circular reddish lesions on the abdomen.
Hello. Good evening, ma'am. Can you hear me?
Yes, I can hear you.
Ma'am, number 5 cases, I'm not very sure, to be very honest. I'm a first-year pathology resident. But what I'm guessing is either it's query because of the fungal hyphae, maybe mycosis, or...
I am not able to hear you. Your voice is breaking.
Ma'am, hello?
Yes, please continue.
Ma'am, can you hear me?
Yes, we can hear you. Please go ahead, Melong.
Ma'am, I'm so sorry. I'm just a first-year resident. I'm just trying to, the case you have given me, the picture you have given me, I'm trying to present, but I'm not very sure,
It's
ma'am.
all right. It's okay. Don't be worried. Just describe what you're seeing here. It's fine. What is the pattern you're seeing in the dermis? Are you seeing any infiltrate?
Ma'am, the only thing is that I'm a first-year graduate, so I'm just saying like the other things I'm not like it's everything's
It's all right. It's all right. Don't worry about that. All of us are learning. Okay, don't worry about that. So just describe what you're seeing here. You know which is the dermis and epidermis, right?
Yeah, ma'am.
So is there any pattern of infiltrate that you're seeing in the dermis?
Yes, ma'am.
Okay, what is it?
So, ma'am, either is like the hyphae, is it either an artifact or proper mycosis.
Okay. Okay. Okay, we'll go to that. But right now at this magnification, what are you seeing? There's a reason that I've given you this.
Yeah,
biopsy.
yes, ma'am, yes, ma'am.
We'll go to the higher magnification features later. Let's talk about what we are seeing here.
Yes, ma'am.
Would you say this is a good biopsy? Are you happy with the thickness
no.
or the dimension of the biopsy that you're looking at?
No, ma'am.
It's very small, isn't it? It's almost you're
Yes, ma'am.
seeing only up to mid dermis level. So this is what we would
Yes,
call as
ma'am.
a suboptimal biopsy,
Yes,
right?
ma'am.
So the
Yes,
reason
ma'am.
for my giving you this biopsy is that sometimes even in what we think is suboptimal, there is something. So we have to be careful. Do you
Okay,
see
ma'am.
any infiltrate in the dermis?
Ma'am?
Are you able to make out? You've seen so many cases with dermal infiltrates till now. So here,
Yes, ma'am. Yes, ma'am.
anything?
Yes, ma'am, but not that obvious, ma'am.
Not that obvious. So that's, I think you've picked up the findings very correctly. So there is a very minimal or a very mild perivascular infiltrate, and
Yes,
combined
ma'am.
with the fact that this is a superficial biopsy, it's very easy for you to pass it off, right? As
Yes, ma'am.
okay,
Yes,
it's
ma'am.
non-specific. But there is a clue. What is the clue? Can you tell me what's the clue here? Even the epidermis, the thickness, everything looks okay. So there doesn't seem to be anything wrong there. But where is the pathology? You picked it up. You already said it.
Yeah, ma'am, here.
How is stratum corneum?
Stratum corneum, yes, ma'am.
Is it looking normal?
No.
No, right? So what is the change? What would you call this? So this is compact orthokeratosis. Right?
Yes, ma'am.
So the only significant finding that you have here is that there's a whole lot of compact orthokeratosis, and maybe
Yes, ma'am.
there is slight parakeratosis if you look somewhere focally. But what is this? What are these? You said it right. You picked it up. Tell me what these are. Can you appreciate the hyphae? The spores and the hyphae in the stratum
Yes,
corneum?
ma'am. Yes, ma'am. Yes, ma'am.
Yes, isn't it? So you can
Yes,
see
ma'am.
these are, so this is not an artifact. So you were very correct in your observation. So these are the hyphae and spores that you are seeing in the stratum corneum, in the altered. So this is a very, very subtle case, very easy to pass it off. So this is perhaps what would come under the category of invisible dermatosis, where it looks like there's nothing wrong, right? But
Okay,
if you
ma'am.
go higher, if you look, so the clue is in the stratum corneum, the altered conification. So
Yes,
which is
ma'am.
why it's a very good idea, at least in our center, for every inflammatory skin disease, we do a
Special stain, ma'am.
What stain would help you?
Yes.
Yeah, PA stain, right? It's
Yes,
a good
ma'am.
idea to do a PA stain. So this was a case of tinea or dermatophyte infection. So sometimes the infiltrate is not there at all. Sometimes you see eosinophils. And usually one thing you do not see in dermatophyte infection is a whole lot of spongiosis.
Yes, ma'am.
So you have this subtle altered conification, but you don't see, like, you saw the vesicle formation, right? So you
Yes,
don't
ma'am.
see spongiosis of that extent. Usually if that is there, you don't see dermatophytes.
Yes, ma'am.
And of course, textbook talk about this famous sandwich sign. So do you know what the sandwich sign is? It's nothing but two different types of conification. And
Yes,
they
ma'am.
say that the hyphae like to sit there, right?
Yeah,
So you find the hyphae in between two different patterns of conification.
yes, ma'am.
So that is the sandwich sign.
Yes, ma'am.
So inviting the comments of the chairpersons.
Dermatophytosis is very common in our country. Compared to that, very uncommonly it is being biopsied. But when it is biopsied, at least we should diagnose it. So it's excellent that Dr. Rajalakshmi is doing PA stain for every inflammatory skin disease biopsy. I think that's very good. The skin lesions in dermatophytosis can vary once the patient starts using combination creams containing steroids, and then the diagnosis of fungal infection becomes difficult to make out. That's why we call it tinea incognito. And this could be one such patient where inflammation was minimal and the hyphae are numerous. So that may be one of the reasons this patient may be using a steroid-containing creams. In fact, such steroid-containing creams with antifungal combination should not be promoted. That is an important actually aim of one of our, one of the aims of our association, Dermatology Association also. So I'll just make a mention of that here. Thank you.
Nice case, dermatophyte. Actually, nomenclature of dermatophyte depends on the site of the involvement. So it could be tinea pedis if it involves the feet. So first year PG students should know what are the different things, where you have to call what. And then tinea cruris if it is involved genitalia, and tinea corporis of the torso, and tinea capitis if the dermatophyte infection in the head. So different types of nomenclature, and very good lesson in this case. So everyone should perform pass in this case. So this is very nice discussion. So we can go ahead. That's all from my side.
Thank you. So we'll move on to case number 6. Is Dr. Saujanya here? Saujanya is not here. Is Dr. Abdul here?
No, ma'am, not yet.
Okay. Tina, so can Tina take this case?
Okay.
Yeah, so this is a 36-year-old farm worker who developed a verrucous plaque on the leg after minor trauma. I think the history itself is a dead giveaway. One second, let me just open the slide. Yeah, right. You can start, Dr. Tina.
Section from skin shows pseudoepitheliomatous hyperplasia.
Okay.
There are some intraepidermal collections.
What is the infiltrate in the dermis? Can we start with the dermal pattern?
Superficial inflammatory infiltration.
Okay. What is the pattern? How is it distributed? Would you call this perivascular? Would you call this lichenoid? Would you call this something else?
Diffuse superficial.
Yeah, superficial is right. But what's the pattern? I'm pointing out. I'm trying to delineate what you're seeing. Are they slightly larger than the perivascular infiltrates that you would see?
Yes.
So what is the term that you would like to use for that?
Interstitial.
So these are nodular, right? So when you have a slightly denser infiltrate, you refer to it as a nodular infiltrate. So you're right. So there's a nodular dermal infiltrate. And like you rightly said, what are the epidermal changes?
Pseudoepitheliomatous hyperplasia.
Okay. And there's something else that you described?
Neutrophil collection within the epidermis.
Yes, very good. Okay. Now, can you tell me what this dermal infiltrate is made of?
Predominantly, ma'am, neutrophils.
What are the cells that you're seeing in the infiltrate?
Lymphocytes. Predominantly
forming something else? Any other term that you could use?
Micro.
What is this? There's one more here. What would you call these aggregates?
Granuloma.
Yes, you're right. So that is a granuloma. What kind of a granuloma is it? So in the beginning, when we talked about introduction, I did describe a few types of granuloma. So which one of them would this fit into? What are the cells comprising this granuloma? What are the cells that you're seeing here?
Histiocytes and lymphocytes.
So here, the ones that I'm pointing to here, there are these two large cells in the center, and surrounding that, there are some cells with spindly or slipper-like nuclei. What are those?
Ma'am, giant cells.
Yeah, these are giant cells. But what are these cells?
Epithelioids.
There's more of that here. They are epithelioid cells, isn't it? So these are epithelioid cells. So these are epithelioid granulomas that you're seeing. And you have a cuff of lymphocytes around some of them don't have too many lymphocytes. So this is a epithelioid pattern of a granuloma that you're seeing. And you rightly said there are several giant cells. Anything else which is striking in this case?
Some pigmented fungal sclerotic bodies.
Pigment incontinence.
Yes. So you are seeing within the giant cells have engulfed these sclerotic bodies or medullary bodies or copper pennies, which are brown in color. So I think in this case, we kind of hit the jackpot because they were right there looking at us, waiting for us to find them. But trust me, that's not going to be the case all the time. So what is this? This is a case of chromomycosis, right? Now, suppose you did not see these fungi, right? You had a similar pattern, right? You had these granulomas, which were tuberculoid or epithelioid granulomas. And like you rightly said, with this kind of hypoplasia, is there any other disease that you would like to think of?
Sometimes can mistake for squamous cell carcinoma.
Any other condition which is quite common in our country?
Leprosy.
Leprosy, ma'am.
Leprosy, no. You will not find this degree of hypoplasia in leprosy. You'll never find pseudoepitheliomatous
Pemphigus
hypoplasia in leprosy.
vegetans.
Anything else?
Pemphigus vegetans.
Pemphigus vegetans would not show granulomas, isn't it?
Yes, yes.
So we are talking about granulomas. Any other granulomatous inflammation? No. More common, very common in our country, an infection. What's the commonest granulomatous condition that you think of? Whenever you
Granuloma annulare.
Won't you think of tuberculosis?
Lupus vulgaris.
Won't you think of lupus vulgaris?
Lupus
Vulgaris, tuberculosis, verrucosa acutis. So all these things could present with marked epidermal hyperplasia. So in fact, in tuberculosis, verrucosa acutis, that's how it gets its name, right? Because there is a lot of verrucous epidermal hyperplasia. So in such a case, if you're suspecting tuberculosis, would you do a Zeal-Neisel stain? If you're suspecting lupus vulgaris or TBVC?
Ma'am?
Is it worthwhile doing a ZN stain? No, usually your ZN stain is going to be negative in such instances. So in this case, it's very fortunate that we found the fungi, but very more often, and also this is a very nicely done biopsy. So very often what happens is that there is a lot of, hyperkeratosis. So we end up getting shaved biopsies. So we may not appreciate the entire thickness and, we may not find the organism. So it's very important to do an adequate biopsy whenever you're suspecting a fungal infection. So as you rightly said, this is a case of chromomycosis and you've described all the epidermal changes, right? So tuberculosis has to be kept in mind as a differential. They can look pretty identical. Any comments from sir and ma'am?
Just want to mention that there are some other conditions also which can mimic this, like fixed cutaneous sporotrichosis and blastomycosis, even the lobomycosis, that's rare of course in this country, but they can mimic the appearance without, of course, these typical bodies. We would not be difficult to differentiate. Yeah. And as far as the clinical picture is concerned, in lupus vulgaris, we see apple jelly nodules on doing diascopy, that is pressing a transparent glass slide onto the granulomatous plaque. Whereas in tuberculosis verrucosa cutis, because there is excess verrucous hyperplasia and hyperkeratosis, those apple jelly nodules are not so easily seen. Thank you.
Yeah, very nice case. This is clear cut. There is presence of copper so there is no any confusion of this chromomycosis. But PG should know what are the different complications this chromomycosis can lead to in the form of ulceration, in the form of secondary bacterial infection that might confuse. Sometimes it may lead to lymphedema. So that leads to elephantiasis too also, and sometimes myosis. So these are the complications PG should know what are the different complications this chromomycosis can lead to.
Thank you, ma'am. And again, like sir pointed out, the multitude of fungal infections that you could see, the differential diagnosis would depend also on the geographic area. It depends on where, which part of the world you're seeing this. So according to the common fungi there, you would, make up your differential diagnosis. So moving on to case 7, this was a 39-year-old lady with infiltrated nodular lesions over the face, ears and arms with loss of eyebrow hair. So I think we'll come back to Ishita. Is Ishita there?
Yes, ma'am.
Ishita, can you take this case? Sorry, it's taking a little time to load. Yeah, go ahead.
Okay. Yeah, H&E stain sections are showing normal looking epidermis, but we can see that there is a hypocellular zone in which is separating epidermis from papillary dermis, which is called as Gren zone, and we can see dense inflammatory infiltrate.
I'm deliberately not going to the higher magnification because there is something I want you to pick up on scanner.
The infiltrates.
So this pattern is like virtually diagnostic of this disease. So can you tell me what is the pattern that you're seeing here? It's a nodular pattern. That's right, because we are in the spectrum of nodular dermal infiltrates. Anything striking about this pattern? Isn't it very peculiar? You see this?
Storiform.
So,
you see this?
What is
macrophages?
Can you tell me what pattern, what is the term used to refer to this pattern? It is a nodular infiltrate. It's in a curvilinear pattern, isn't it? So these are oblong or curvilinear. So there's a classical curvilinear pattern. And yeah, now go ahead.
Yeah, at this magnification, we can see the hypocellular zone, which is separating.
So this is what you mean. So this is the zone. Okay. Do you want me to go higher on the infiltrate?
Yes, ma'am.
Yes, there you go. How would you describe the infiltrate?
The lymphocytes mainly comprising of spindle-shaped cells with macrophages.
What kind of macrophages are you seeing?
Foamy vacuolated.
Yes, so they are foamy macrophages. There are a few lymphocytes. There are also some, like you said, some spindle cells. So there are a few epithelioid cells here. Anything else apart the macrophages, which is a giveaway. This is a very important clue to this disease. Can you see what's within the cytoplasm? What's the color of the cytoplasm here?
Like maybe.
Is it pink? Can you see this? Can you see what I'm pointing to?
Yes, ma'am.
So this is
It's not
called
feeling.
as the blue-gray cytoplasm. Okay.
Yeah, yes, ma'am. Yes, ma'am.
Typical words
Yeah,
that's
yes,
used to
ma'am.
describe. So you have foamy histiocytes with blue-gray cytoplasm, right? So what
Yes,
is
ma'am.
the blue-gray? We'll come to it later.
Yes, ma'am.
And I'd like to point out one more feature. So you've rightly identified that there are foamy histiocytes. So can you tell me what's happening here? What is this and what is surrounding this? What is the structure at the center and what's happening around it?
Necrosis, ma'am.
Necrosis? No, this is not necrosis.
Oh, no.
You
Sorry,
can
sorry,
see
ma'am. Sorry,
cytoplasm, nuclei, everything very
Yeah,
well. So it's not necrosis.
Yeah, sorry, ma'am.
What is the structure?
It looks like a nerve.
Perineum.
It is a?
It looks like a nerve is
It looks like a nerve.
infiltrated
You're right. It looks like a nerve. So does the nerve look intact or does it look
infiltrate.
destroyed?
Perineural.
Yeah, so you can see the structure of the nerve. What's happening around the perineural? How would you describe this appearance? You see these layers, onion skin appearance around the perineurium
Onion ring.
and the infiltrate, that is the foamy histiocytes and the lymphocytes there, isn't it? And in fact, I can take you to another area. So the same thing here. Do you see this? You see the nerve at the center and you see this perineural hypoplasia and then you have this infiltrate. Now, this is a very, very important clue to this. So now, I think it's fairly easy now. Do you want to make a diagnosis? What's your diagnosis?
It can be leprosy or other diagnosis can be histioid leprosy because there are more of like spindle-shaped cells also.
Okay, so basically you stick to leprosy, right? So it could be lepromatous or it could be like you said, histioid leprosy, right? So histioid leprosy is nothing but it's a variant of lepromatous leprosy where you would see only spindle cells. So that's a differential diagnosis for a spindle cell tumor. Now, what are these blue-gray cytoplasm? What does this signify? Can you tell me?
Ma'am?
Yeah. What does this blue-gray cytoplasm denote? What will I find there? What special stain should I do next? What stain should I do to confirm a diagnosis of lepromatous leprosy?
Yes.
PS, how would PS help me? No, PS would not help me.
White ferrocous stain, ma'am.
White stain. So if I do a white stain, I'm going to see bacilli which are loaded in those cells, right? So the blue-gray cytoplasm is nothing but the bacilli or the globi which are there in the cytoplasm, right?
Okay.
So even without the white stain, you can make it out, right? So the diagnosis in this case is lepromatous leprosy. It's a borderline lepromatous leprosy because you're seeing the onion skin appearance of the perineurium with the infiltrate, right?
Yes,
but what is characteristic of leprosy pattern in both the lepromatous and the tuberculoid spectrum is the curvilinear pattern, right? So in fact, it's better appreciated in a borderline tuberculoid leprosy. I did not show you that. And in lepromatous leprosy, you get a diffuse or a nodular infiltrate. So this is a little algorithm to help you to classify leprosy accurately. In fact, 80% of the cases we see are tuberculoid and a few are lepromatous, right? So if you're looking at the tuberculoid spectrum, so these are the features that you have to consider before you classify. One is the erosion or the basal cell changes in the epidermis and the presence of caseation or marked swelling within the nerves. So leprosy, you don't find necrosis within the granulomas, right? So if at all you do find caseation, it is within the nerves in case of TT leprosy, right? Then you look at the giant cells, the lymphocytes, the absence of the Grenz zone. This is for the tuberculoid spectrum. And for the lepromatous spectrum, what helps you to differentiate, of course, other than the presence of combination of foamy histiocytes and epithelioid cells, is the presence of onion skin perineurium with the infiltrate. So I think this is something which none of us should miss. And it is not necessary that always patients will come with the typical history of lepromatous leprosy. In fact, we have seen patients coming with type 2 reaction de novo without a previous history or anything suggestive of leprosy. So I think our index of suspicion should be very high when you see a foamy infiltrate, or especially if you're seeing foamy histiocytes in paniculitis and things like that. So we should not miss leprosy. So any comments from the chairpersons
Just
for
want
this
to add
case?
one thing for the PG students. So about the reaction, type 1 and type 2 reaction. So these two reactions can be seen in both type of leprosy, in the tuberculoid leprosy as well as in the lepromatous leprosy. This is very important to know, and with the various points we have to look while seeing the slides of leprosy.
I would just like to make a point about the diagnosis of lepromatous leprosy, since you showed a beautiful slide of it. The clinical diagnosis of lepromatous leprosy is difficult to make till it is very late and obvious, with nodules or with swelling of the face, what we call infiltrated face, or leonine faces, or when the hands or fingers are swollen and tapering, because the sensations in lepromatous leprosy are affected late. So you may not get the clinical history of loss of sensation in cases of lepromatous leprosy. So you need to be aware of this aspect while diagnosing lepromatous leprosy. Thank you.
Thank you. Another point I'd like to mention in tuberculoid leprosy is regarding the nerves. Here in lepromatous leprosy, the nerves are relatively better preserved. So you can see the onion skinning. But what happens in tuberculoid leprosy, especially if the biopsy is inadequate, is you don't see any nerves at all because the nerves are completely gone. So in such a case, you may have problems definitively signing out as leprosy. So there are, papers that recommend that you use the S100 stain and things like that, but it may not always be helpful in clinical practice. So the key in tuberculoid leprosy is to get a good, adequate biopsy to include the subcutis so that you can evaluate the neurovascular structures very well. But nevertheless, there are always cases where you don't find nerves at all. And yet the pattern is what helps you, of course, with the clinical correlation. Right. So with that, we'll move on to case number 8, a 30-year-old lady with annular lesions on the arm. Can we come back to Shrija for this case?
Yes, ma'am.
So Shrija, start with the dermal patterns, what you're seeing in the dermis.
There is diffuse inflammatory infiltrate, ma'am.
Yes.
Shrija, I'm not able to hear you.
There is diffused dermatitis, ma'am.
Okay.
And diffuse dermatitis and
when we say diffuse, we generally mean that it's occupying the entire dermis, so that the entire dermis is obliterated. That's what we mean when we say diffuse. Is that what you're seeing here?
not completely, ma'am.
It's not complete, isn't it? So in fact, you have quite a bit of normal dermis in between, and then you have these kind of circumscribed areas. Here it looks well circumscribed, and here not so much, right? Here it appears more loose or discohesive, right? So that's what you can make out on scanning magnification. Okay, let's go a little higher. Now you can describe it better.
Interstitial type of dermatitis, inflammatory infiltrate.
Okay, which is the interstitial pattern? Is this the interstitial pattern what I'm showing you? Or something else? What is this pattern? The one which is in this field. How would you describe this? There is something in the center and you have this sort of a fence around it. What would you call this pattern?
Palisading the.
Yes, you're right. So this is a palisading pattern. So there's something in the center and there are cells surrounding that. And as you rightly said, this is an interstitial pattern, right? So you see this infiltrate that's going in between the bundles of collagen. So you have a combination of a palisading. So here again, you can see a palisading pattern and you can see an interstitial pattern. Okay, so what is the composition of the infiltrate?
Lymphocytes, ma'am.
Okay. What are these cells?
Histiocytes.
Lymphocytes as well as histiocytes, isn't it? So you have lymphohistiocytes. And what's at the center? What is happening here? What is this you're seeing here?
Degraded collagen.
Sorry? You're right.
Degraded
What
collagen.
is it? Degraded collagen. I think
Collagen.
it's better to use the word altered collagen.
Altered collagen.
Necrobiosis. That's exactly
Necrobiosis.
the term that I'm trying to avoid
ma'am.
because it doesn't make sense to me. I prefer to use the term altered collagen. So sometimes it has a more eosinophilic hue and more often than not, it appears slightly basophilic. This slide is a little lightly stained, so you're not able to make out the basophilic hue. So let's stick to the word altered collagen. So you have altered collagen around which you have these histiocytes and lymphocytes. And anything in the epidermis, is there anything of significance? No, right? So the epidermis looks relatively uninvolved. Okay, so now do you want to attempt a diagnosis or do you want to do any special stains, anything else would you like to do?
For collagen.
You want to do stains for collagen for what? Okay, there's something else here. Do you know what these fibers are? I'm not sure that it's visible, whatever I'm pointing. There are some slender fibers there. There are a few here also. Can you see that?
Yes.
Yes, ma'am.
They have a slight basophilic hue. What do you think those are? That's too thin to be collagen, right?
Yes, ma'am.
So what could it be? If not collagen, it is elastic fibers,
Elastic.
right? So there is some elastolysis also here. So anything you would like to do? Any special stains? Have you reached a diagnosis in this case? Do you know what this is?
Granuloma.
Granuloma annulare.
Yes, ma'am.
So this is a case of, as you rightly said, this is a granuloma annulare.
Annulare,
And generally, in granuloma annulare, we find mucin in the center of the granulomas, along with the altered collagen. Sometimes you find elastolysis. So granuloma annulare has certain variants. Let's not worry about that. But you have altered collagen and you have mucin in the center. So this is a granuloma annulare. Okay. Now, when you have palisading granulomas, so you need to know. So generally, this is the famous red and blue granulomas list. So whether you see mucin or nuclear dust at the center, which appears blue, or you see something red, like hyalinized collagen or fibrin or degranulated eosinophils, right? So your differential diagnosis would depend on that. But what you're seeing, what you saw is a classic, and generally people classify as interstitial, palisading, etc. So you see that very often you have a mixture of patterns. So you can't really place it in one particular pattern. So that was a case of granuloma annulare. That was, I think, pretty straightforward. Any comments from the chairpersons?
I would like to just mention here that not uncommonly you will come across clinically papular lesions in granuloma annulare, especially over the forearms, arms, bilaterally, and those are more common in diabetics. With increasing number of diabetic population in our country, this type of cases of granuloma annulare, which are not annular, are increasing. So it did not necessarily come as annular lesion, maybe just papular, but usually it is bilaterally symmetric.
Yes.
Thank you.
Yeah, very correctly said. So it is looking like sometimes small raised bumps only, and the cause is unknown of this. So sometimes we can say this could be a secondary to some other primary cause behind this granuloma annulare.
We'll move on to case number 9. A 12-year-old girl with multiple purpuric spots over the lower limbs and abdomen. And she also has intermittent pain abdomen. So, Shrija, would you like to take this case? Shrija is there?
Yes, ma'am.
Yes, Shrija, you can start describing.
Ma'am, as in history, there is abdominal pain, so there is some systemic disorder also. So
Okay, right. So you've interpreted that correctly.
yes, so there is inflammatory infiltrate, ma'am.
Yeah, where? What is the pattern?
Pattern is nodular, ma'am.
Okay, nodular. Yeah, fine. Okay, let's go higher on those nodules.
Yes, ma'am. Nodular pattern and
do you want to comment anything on the color of the biopsy? So far, you've seen all the other biopsies. It's not because the section is thick. Does it look very pink to you? Does it look very pink or very red to you?
yes, ma'am.
It does. Isn't it? Yeah, that's right. Okay. Now go to the infiltrate. What are you seeing here?
Infiltrate.
You're right in that it appears nodular, but where is it? Is it centered around some particular structures?
Perivascular infiltrate, ma'am.
Yes, so it is perivascular and also nodular. And what else are you seeing at the center? What is this? What has happened to the vessels? Do the vessels look so far you saw so many cases of perivascular dermatitis.
Inflammation.
Did not see any changes in the vessels.
Inflamed blood vessel, ma'am.
What do you mean by that? Can you explain the changes that you're seeing here? In addition to the infiltrate, what has happened? Can you make out the lumen?
No, ma'am.
No, right? The lumen is obliterated. Why is the lumen obliterated?
Necrosis, ma'am.
Okay, is it necrosis or something else? What are these cells, do you think? You see these plump cells here which are obliterating the lumen? What are those? Those are the endothelial cells, isn't it? So the endothelial cells appear swollen. They are so swollen that they're occluding the lumen. And what is this stuff here? This very bright pink stuff you're seeing here. What is that? Yes. So that is fibrin. Fibrin deposition in the vessels, or what is also referred to as fibrinoid necrosis. Yeah. So are you seeing that here also? So there is fibrin deposition. I prefer to use the term fibrin deposition in the vessel walls. So that is what you're seeing here, isn't it? See, almost every vessel is showing that, and there's endothelial swelling. Now, can you tell me why this biopsy is looking so red or so pink? What are these here? All these lakes. Yeah, so you're seeing a lot of red cell extravasation, isn't it? And if you go to the edge of the biopsy, it's almost like a pustule. It's almost like a pustule formation here. And the epidermis here also looks a bit necrotic, isn't it? Okay.
Yes.
So would you want to make a diagnosis? Anything else or any other finding do you think I have missed describing? I did not deliberately describe something, hoping that you will catch me. What did I miss?
Neutrophilic dust, ma'am.
Yeah, I never mentioned anything about the nature of the infiltrate, right? So there are a few neutrophils, and the karyorectic debris are not very obvious. That would perhaps be obvious in a little earlier lesion. This is a well-developed lesion. So you do have some amount of neutrophils in the infiltrate and very little nuclear dust or karyorectic debris, as you see, right? So what do you want to call this?
Leukocytoplastic vasculitis.
Okay, so you would want to call this as leukocytoclastic vasculitis. Okay. Is there anything in the history for you?
Abdominal pain.
Something
Abdominal
more?
pain.
Yes. So what is the
Not
significance
shown.
of that history?
Renal
Not shown in
Renal function purpura, HSP, ma'am.
HSP.
It could be an IgA associated vasculitis, what was also called as Enoch-Schonlein purpura. How would you confirm your diagnosis?
Ma'am?
Immunofluorescence.
Immunofluorescence. What would it show?
IgA.
Yes. So you would see IgA dominant deficits in the vessel walls, right? So leukocytoclastic vasculitis is a pattern. It's a histopathologic pattern. It is not a clinical diagnosis. Remember that. So there are a whole lot of triggers. There are a whole lot of conditions which could show leukocytoclastic vasculitis, right? Very often we say the question is for, is it urticaria or urticarial vasculitis? So urticarial vasculitis doesn't have a specific histopathologic appearance. That's also leukocytoclastic vasculitis, may or may not find eosinophils, right? So leukocytoclastic vasculitis is a pattern. It's an authentic vasculitis and it's a pattern. So when we talk about small vessel vasculitis, neutrophilic vasculitis, there are three things, that is leukocytoclastic, septic and livedo. And I want to tell a little bit about this livedovasculitis because everyone may not be familiar with this. So now this is livedo reticularis. So this is the clinical appearance of livedo. So it's important for you to know if this kind of clinical appearance is there. What do you see on histopathology? You see this and tell me what is the difference from the slide that you saw. You saw an LCV, right? How does this differ? What's the difference you're seeing? Are you seeing a lot of infiltrate?
Infiltration is less, ma'am.
No, there's hardly any infiltrate, isn't it? There is very little
infiltration is less, ma'am.
Yes, but what are you seeing? What is striking you on this magnification? What's a striking feature?
Extra.
You see the vessels, they are clogged with fibrin and thrombi, right? So
yes, ma'am.
What is called as an occlusive. In fact, some people don't believe in calling it vasculitis. They say livedovasculopathy or livedoid vasculopathy. And with this sort of an appearance, it usually denotes a very serious underlying systemic disease. It could be cold agglutinin, it could be cryoglobulin, it could be lupus, it could be antiphospholipid, it could be hepatitis C, which means that the patient has to be investigated to rule out a systemic cause. So if you see this sort of a pattern, that should ring alarm bells in your head. Now, this is a quiz I have for the audience. So far, I think I've been only asking the students. So this is something for the audience. So let's see. So this was a patient who came with these kind of ulcers on the abdomen and groin. Okay. So she was a middle-aged lady. She came with this kind of appearance. You see how deep and how necrotic looking these ulcers are. And it came to us with clinical differentials of pyoderma gangrenosum versus medium vessel vasculitis. So these were the differentials that we got. And she had undergone a biopsy somewhere else, right? So these were the sections that we got. And if you look at it, there's not really much that you could make out. There seemed to be some dermal sclerosis, and we could see these fat lobules which looked very small, and there was this basophil, what looked like early calcification around them. You You can see the specs calcification. And we said, you know, we really can't make out much. And then we asked for a repeat biopsy. So they did go and they gave us a deeper biopsy, and this is what we saw. So I'm going to ask you all to type in your diagnosis now. Do we have anyone who's typing in the diagnosis?
Variable opinion, fat necrosis, calciphylaxis, mycetoma,
Pancreatitis, mycetoma,
pancreatitis.
eschar, calcification around fat.
Calciphylaxis is by many people.
Okay, so I think whoever's called it calciphylaxis ought to pat themselves on the back. So yes, it is indeed calciphylaxis. So what you're seeing is that almost every single vessel in the subcutis is showing calcification. So, you know, and it turns out that this was a patient of chronic renal failure. So that history was not given to us. So when we went back and asked, we got the history. So this was indeed calciphylaxis. So everything that you see occluding the vessel is not always fibrin or it's not inflammation, right? So you do have other things which can come. And of course, this is, we did do a special stain. Oh, I shouldn't have labeled the stain. So this was a von Cosa stain, which beautifully highlighted the calcium in the vessel walls, right? Now, one point here, you need to see calcification for calciphylaxis. You need to see it in the middle of the lobules in the smaller vessels, because remember, if you go to the septae, the larger vessels can show calcification because of atherosclerotic changes. So that doesn't make it calciphylaxis. So it matters where you see it. Okay, you have to see it in the small vessels in the middle of the lobules, and that's possible if you only have a adequate representative biopsy. Right. So moving on to case number 10. This was a 43-year-old lady with painful nodular lesions over the legs. So Jhansi, do you want to take this case? Yes. Go ahead.
In the dermis, there is nodular type inflammation, ma'am. And in the subcutis also there is inflammation. Paniculitis is there.
Okay. Yes. Anything else?
And the blood vessel is thickened, ma'am. Thickened wall is there, ma'am. And
Okay.
within the blood vessel also the endothelial cells are little prominent.
Okay. Can you really make out the endothelial cells?
Ma'am, there's fibrin necrosis.
Okay. Okay. What else? What else is happening in this vessel? What is this?
Necrosis, ma'am.
Fibrin material.
Fibrin.
Fibrin and necrosis, ma'am.
Fibrin. Okay. And what is surrounding the vessel? What is the infiltrate made up of?
Neutrophils.
Neutrophils, ma'am. Lymphocytes.
Okay, you have an admixture of neutrophils.
Neutrophils.
Yes,
and
ma'am.
like you rightly said, your observation, what is happening in the fat over here? It's spilling over into the adjacent fat. So there's a little bit of paniculitis.
Yes,
What
ma'am.
about the dermis, the superficial dermis and epidermis? They look relatively
Normal.
isn't it? Right. So
ma'am.
there's a little bit. So the pathology is centered in the vessel, I mean in the subcutis, and it's around the vessel. So what kind of a vessel do you think it is?
Medium
Solve this problem.
Medium sized.
Medium size.
Small size, medium size, ma'am.
Is it an artery or is it a vein? You could get both in the subcutis, isn't it? How do you decide whether it's an artery or a vein? Because your diagnosis will depend on that. Now look at this. This is another cross section that you have. So is it an artery or a vein? That's the most important question that you need to answer, isn't it? Yeah.
Second number 3.
Is it an artery or it's a
Second
thrombophlebitis?
artery.
I'm artery.
Now, on what basis are you saying it's an artery? You have to justify your choice.
It's thickened and the lumen.
It's not always easy when you have such a dense infiltrate and you have so much of inflammation, you're not seeing the wall, everything's obliterated. It's a bit difficult to make out artery versus vein. So in that case, what are the clues that help you? So here's the list. So vein usually has a larger lumen. It's more oblong or oval. Whereas arteries have a smaller lumen, thicker wall. They are round in contour. That is provided you're seeing the transverse section. And of course, we give a lot of importance to the presence of a continuous internal elastic lamina. Where do you see that? You see that in an artery. So when you see an infiltrate like this, when you see a vessel like this, we would like to do a stain for elastic fibers. You can do the Verhoef stain for elastic fibers.
Yes,
And again, it depends on what stage of the disease you're looking at. If it's too early, if it's just the infiltrate without disruption of the wall, it could be intact. Or if it is too late, you may not see anything at all if it's returned to normal, right? So in this stage, if you do, in fact, in this case, we did do the Van Giesen stain, the elastic Van Giesen stain, and it did show disruption of the internal elastic lamina. So the diagnosis was, in this case, this was a medium vessel vasculitis. It was an arthritis and most likely a polyarthritis nodosa, right? So the point that you need to remember for diagnosing a medium vessel vasculitis, you need a biopsy that's very deep and includes the subcutis. So if you do, even if you're doing from the nodule, if you do a superficial punch biopsy, you will miss the vessel. So we recommend, if they can't do an incision biopsy, we say that do a double punch. So what's the double punch technique? You take one punch and then again go down the same site and take another punch, right? So that's one way of making sure that the vessel is sampled. And then in late stages, you could see granulomas. The granulomas can be non-specific. It doesn't point to anything else. So you could see granulomas in a PAN2 or even in a thrombophlebitis, you could see a polyarthritis nodosa. And another point to note is that these lesions could be very focal and segmental. So one level you may see a normal looking vessel and then you have to go on taking multiple serial sections. If the clinical suspicion is strong, we always do a lot of serial sections in order to identify that there is no segmental or focal involvement, right? So this was a case most likely of polyarthritis nodosa. Okay. So can I ask for the comments from the chairpersons?
I mean, you already mentioned about the difficulty in demonstrating the arteriole. I would just add that many cases present as livedo reticularis with gangrene of one of the digits or toes. And such cases, it's even more difficult to decide the exact site of biopsy when there are no nodules. So one really has a difficulty, and multiple biopsies may be required actually. Sometimes the Doppler test is helpful.
Yeah. So medium-sized artery vasculitis, it do occur sometimes in childhood. So it is very important whether it is polyarthritis nodosa or cutaneous polyarthritis nodosa, or it could be Kawasaki disease. So when the diagnosis is medium-sized vasculitis, age is also very important, and taking account of the history of the patient. Thank you.
Yes, that's a very important point you made, ma'am. Thank you very much.
Just to expand on that, there is one variant of segmental cutaneous periarthritis nodosa, which one should be aware. Only one side may be affected, and only one limb, one side may be affected in segmental periarthritis nodosa. Just to mention about that.
Okay. Thank you, sir. Okay, we'll move on to case number 11. A 56-year-old man with blisters all over the body and presence of oral erosions. So we'll move to this case. Who will take this? Jansi, do you want to take this?
Yes, ma'am.
Can you tell me what do you think is the site of this biopsy? I'm not giving you the site. But can you take a guess from looking at this?
Hair follicles are more, ma'am.
Yes, you're seeing so many terminal hair follicles, isn't it? So this could be from the
Scalp. Scalp.
right. You're right. It's from the scalp. All right. Go ahead. Go ahead.
We are seeing perivascular infiltrate, ma'am, in the dermis.
Yeah, you're right. Okay.
In the epidermis, there is a blistering disorder, ma'am.
Yes.
Blister is intraepidermal, mostly suprabasal blister, ma'am.
Very good. So what does it contain? What are the contents?
Acantholytic cells are there, ma'am.
Yes, very good. So these are the acantholytic cells, which are nothing but the keratinocytes, which have lost their adhesion. They are rounded up. Okay. What else? Anything else? What is this? What are you seeing here?
Which one?
Basal cells.
Basal vacuolation.
No, this part. You see this? I'm pointing to this. I don't know why I can't get the laser pointer.
Tombstone
Let me try to get it. It's not working. Okay. Yeah. So what is it?
Tombstone appearance.
Tombstone.
Tombstone appearance.
Tombstone appearance.
So these are the villi. So these are the dermal villi which are projecting, which are lined by these keratinocytes. Okay. Anything else? Anything else? I'm showing you something. What is happening here? Here, what structure is this?
Hair follicle.
Hair follicle.
It's a hair follicle, right? So what's happened to this hair follicle? Is it looking normal?
No, ma'am, it is compressed.
No, ma'am.
What is happening here? Do you see this acantholysis which is extending throughout the length of the follicle?
Yes.
Yes, ma'am.
Not just the follicle, it's also extending into the sebaceous unit.
Sebaceous unit.
Yes.
Yeah, so there is extensive acantholysis with involvement of the
Hyalosebation.
adnexal structures, right? Okay, so you can see here also. See this? So there is extensive adnexal involvement, right? So this is a intraepidermal acantholytic blistering disease with adnexal involvement. So what do you think it could be?
Pemphigus
vulgaris.
Yeah, so, okay, all right. 1 second. So you are right. It could be pemphigus vulgaris. Would you like to do something else?
Immunofluorescence.
Is it necessary in this case? It's pretty classical, isn't it?
Yes, ma'am.
So do you want to do immunofluorescence in every case?
No, ma'am.
Not really necessary. Okay, we'll talk about immunofluorescence, but we'll finish the next case and then talk about immunofluorescence. Okay, so we'll go to case number 12. This was a 72-year-old lady with pruritic papules and vesicles over the leg. Who will take this case? Bhagishri?
Yes, ma'am.
Yeah. So this is every dermatopathologist's dream biopsy. So the entire vesicle has been excised and sent to us. So it's very rare that we see this. So don't think that I see biopsies like this every day. I see punch biopsies only. So this was one of those rare instances where we got such a big chunk of tissue. Okay, come on, go ahead and describe.
Section shows subepidermal blister above the basement membrane.
What is the dermal pattern?
Ma'am, dermis shows mixed inflammatory cells infiltrate in the superficial dermis.
Okay, fine. And then there is
interface.
Yes, ma'am.
Like you said, subepidermal.
Yes, subepidermal blister.
Go ahead.
Yes, ma'am.
Okay. So there is a subepidermal blister. How do
That
you know it's
contains-
subepidermal?
Ma'am, it's just above the basement membrane.
It is between Stratum corneum and dermis.
Sorry, ma'am. Dermis layer. Sorry.
Stratum corneum? No, not stratum
Stratum
corneum.
basal and
Ma'am, it is basal.
Okay, so you're seeing the entire thickness of the epidermis on top. And do you see any lining at the roof of the blister? You don't, right? So that's how you know that it is subepidermal. What does the blister contain?
Ma'am, it contains predominantly eosinophils.
Predominantly?
Eosinophils.
Eosinophils. Excellent.
Yes,
okay,
miss.
so this is
Eosinophils.
eosinophil-rich blister, right?
Yes, ma'am.
Anything else? Are you seeing any acantholytic cells?
Yeah. Yes, ma'am.
Do you see acantholytic cells? No, there are no
No,
acantholytic
ma'am.
cells. Okay. And what about the dermal infiltrate? What cells are here?
Ma'am, predominantly they are mixed.
You see lymphocytes here also, right?
Yes, ma'am.
Okay,
They are
but the
mixed.
most interesting finding in this case is not in the blister. I always like to go and look at the side of the blister. What am I seeing here? Can someone tell me? What is happening here?
Spongiosis.
No, spongiosis. Do you see these eosinophils lined up along the basement membrane?
Yes. Yes, ma'am.
Am I emphasizing this feature? Okay, what's the diagnosis in this case? I think this is pretty straightforward. You should be able to tell me. So this is a
Bullous pemphigoid, ma'am.
Yes. So this is an elderly lady with a subepidermal eosinophil-rich blister, right? So the diagnosis
Yes,
bullous pemphigoid. Would you
Yes,
like to
ma'am.
do something else? Perhaps you would like to do immunofluorescence.
Immunofluorescence.
Yeah. So the importance of knowing this finding, what is on the side, is because it's not always that patients with bullous pemphigoid present with blisters, right? They could present
Yes, ma'am.
with intense itching and urticarial lesions. So suppose the biopsy is taken during the urticarial phase of this lesion, you will not see blisters. Instead, what you will see is, you may see spongiosis, you may see dermal eosinophils, but what gives you the clue is these eosinophils which are lined up on across the basement membrane. Why are they lined across the basement membrane? Because the target antigen is there. We know what is the target antigen. I'm going to come to that shortly, right? So this is a clue. So if you get a lesion, an early lesion, biopsy from a pruritic lesion or an early lesion where there is no vesicle or blister formed, this is a good clue, eosinophils along the basement membrane. So this is a good clue to a diagnosis of bullous pemphigoid, right? We'll talk a little bit about immunofluorescence in this context for bullous lesions. So it is good to do DIF if you have the facility. It is not necessary that you must do it in all cases, right? But there are, because ours is a, it's a teaching hospital, so we end up getting, even in classical cases, we do get
Yes, ma'am.
immunofluorescence. But in practice, it is not necessary to do in every case. So whenever we interpret DIF, there are 4 questions that we ask ourselves. Where is the fluorescence? What is the pattern? What antibodies account for it? And what is the intensity? So the intensity is less important in this context. So when we talk about where is the fluorescence, so what is the pattern you're seeing here? Can you tell me?
Basket weave. Basket weave.
It is in the epidermis.
Fishnet
and
pattern.
The fluorescence is in between the cells. This is intercell. Actually, it should be called pericellular. It's not intercellular. It is pericellular positivity. But by convention, we call it ICS, and this is likened to a fishnet. And this fishnet pattern is characteristic of which disease? Where do you see this?
Pemphigus vulgaris.
In pemphigus, not just vulgaris. In all types of pemphigus, you see fishnet pattern. Now here, in this case, where is the fluorescence? Where is the location of the fluorescence?
Dermoepidermal.
Yes, it is at the basement membrane zone or the dermoepidermal junction. Now there are 3 different patterns that you're seeing here. What pattern is the first one?
Linear, ma'am.
That's a fine linear pattern. Next you have a granular pattern. And then you have a glassy linear pattern. And if you look at this glassy linear pattern, it looks like smudged. It looks like a linear pattern. Somebody took an eraser and ran it over that, right? So just in the basement membrane, you notice it's also in the blood vessels. Now that's a clue for this disease. I'll come to that. right? Next is, where is the fluorescence? This is another pattern. Where is this? Is it in the epidermis or the dermis?
Looks like in the dermis.
Dermis, ma'am.
It is in the dermis. Which part of the dermis? It's in the tips of the dermal papillae, right? So these are the different patterns that you see. This is a granular pattern at the tip of the papillae.
Tip of the
right? Yeah. Now here, what are you seeing? It's also in the vessels, isn't it? You're also seeing fluorescence. This is the glassy linear pattern in the vessels. So, like I said, what's the significance of these patterns? Intercellular pattern is seen in all variants of pemphigus. So, pemphigus variants cannot be differentiated on the basis of immunofluorescence alone, because most often you get IgG and C3 in both. The only variant you can distinguish which presents as a pustular dermatitis is IgA pemphigus, because you get intercellular IgA positivity. Now, basement membrane zone patterns, this is a little more complex. C3 with or without IgG, most commonly seen in bullous pemphigoid. Linear IgA disease, if it's IgA. The glassy linear pattern is very characteristic of porphyria. Okay. Now, let's understand a little more about immunofluorescence. In subepidermal blistering diseases, DIF is not always enough, right? Because there are a lot of overlaps, especially if you take bullous pemphigoid and epidermolysis, bullosa acquisita, both of them give a basement membrane zone positivity. But as you know, the BP antigens 1 and 2 are located in the hemidesmal zone, which is above the level, which is at the level of the lamina lucida. Whereas the collagen 7, which is the target in epidermolysis bullosa acquisita, is located in the lamina densa. So is there something we can do to separate these? Yes, and that technique is called as the salt split skin. So the skin biopsy is incubated in 1 molar sodium chloride, and then that induces a split after 24 hours. And then if you do your IF, the two will get separated. Okay. Now here, this is what we call as a roof pattern, which is seen in BP, linear IgA and certain other diseases. And this is the flow pattern, which is seen in epidermolysis bullosa acquisita and certain variants of pemphigoid. Now, this can be quite cumbersome to do, right? So what we do in our setup is we do what is called as a biochip method, where you use a single serum sample and it has a superior sensitivity. You can pick up many conditions together. So what is this biochip mosaic? So it contains 6 substrates. You have the monkey esophagus, you have the salt split skin, and then you have the cell lines, desmoglein 1 and 3, and then 230 and 180 are quoted as recombinant spots, right? So this is a mosaic which is commercially available, and with this you can use this to separate various types of subepidermal bullous diseases, right? Of course, the confirmatory test is ELISA, but at least from this, you can pick out the ones which are, common, which are not complicated, and then you can separate out the ones which would perhaps need an ELISA. So now I have a case for the audience. So if they are still there, so you can take this case. So this was an elderly male. He actually came with this lesion. You see the scalp, he had this eroded lesion on the scalp with hair loss. That was his complaint. This came much later. I'll tell you what this is later. I'm not going to talk about this later. So this biopsy came to us with a diagnosis of LE. So they thought it was a DLE. And this is what we received. So what are we seeing here? You see a subepidermal blister, right? But what is the difference between what you saw in the earlier case and this one? Do you see any contents? You don't see anything here, isn't it? It looks cell poor, right? There are a few eosinophils in the infiltrate. But remember, I told you this is a biopsy from the scalp, and you have seen a scalp biopsy earlier, the pemphigus case. What is missing?
Hair follicles.
You're not seeing hair follicles. You're not seeing any adnexal structures, isn't it? So there is absent adnexal. It looks like there is scarring or there's fibrosis, and this has retracted, right? So it looks like there's a lot of fibrosis, and there are these eosinophils. So we said, okay, let's do a derm mosaic or a biochip, and this is what we got. So the salt split skin substrate showed positivity on the roof, and the BP 230 was positive. Okay. And if I go back, and on the day, in fact, we did the derm mosaic or the biochip, this patient also developed oral erosions, right? Till then, he did not have oral erosions. So somebody wants to take a guess at the diagnosis? What are we looking at?
Pemphigoid.
Yes?
Mucous membrane pemphigoid, ma'am.
Yes, we are looking at mucous membrane pemphigoid or cicatricial pemphigoid. So this was a case which we could solve because we had the biochip. So that was just an example. And this is just to show you, this is an algorithm to show you how to approach blistering diseases with the combination of DIF pattern, histopathology, and those cases which would require further studies. For example, paraneoplastic pemphigus, or what is now called as the paraneoplastic systemic autoimmune syndrome. Now, this is a case with a high incidence of internal malignancies. So when do you suspect it? When you have a combination of intercellular and basement membrane zone patterns, but this is not diagnostic. And neither does the biochip have the substrate which is confirmatory. Okay. The confirmatory substrate is the rat bladder because it is rich in plugins. So either you need to do an indirect IF with a rat bladder substrate, which is available separately, or you could standardize in your center, which is a little difficult to do. You could do an ELISA for the plugins. Okay. Now coming to subepidermal blistering diseases, it's a little more complex. I'm just talking about the autoimmune subepidermal blistering diseases. You look at whether the pattern is linear or granular, and then again you could use the salt split skin if you have a doubt between bullous pemphigoid or epidermolysis bullosa and some of the rarer variants of bullous pemphigoid. Right? Okay, I'm not going into the others for lack of time. So any comments from the chairpersons?
So we can go ahead.
I think just brief comment that you already mentioned about the early lesion of bullous pemphigoid, what it shows. Another pattern it can show is an intraepidermal spongiotic vesicle, and same is true for even pemphigus, where there may be intraepidermal spongiotic, neutrophilic spongiosis. So these patterns also should be kept in mind when the clinical diagnosis is query pemphigus or query bullous pemphigoid. Thank you.
So thank you. I missed saying that. That's very right. Ma'am, any comments from ma'am?
No, we can go ahead.
Okay. So moving on to case number 13. This is, we are coming to the last 3 cases, so we should wrap up quickly now. So it's a 26-year-old woman who presented with tender erythematous nodules over both legs. And after about a week or so, it turned dark. So this is the typical history. So Dr. Mylum, you want to take this case?
Based on my diagnosis, on the findings, I find it's erythema nodosum, ma'am.
Okay, can you describe what you see? We'll come to the diagnosis part later.
Yes, ma'am.
Yeah, please.
There's an edematous septa with prominent mixed cell, ma'am, with inflammatory infiltrate, ma'am.
So what can you make out on scanning magnification? Where is the pathology? Is it in the epidermis, dermis, or the subcutis?
Subcutis.
Okay, so it is in the
ma'am.
subcutis. So although
Yes,
there is a slight dermal perivascular infiltrate, it's not very significant because the most striking changes are in the subcutis. Okay.
Yes, ma'am.
Which part of the subcutis is more affected? What are the parts of the subcutis? You have the lobules and you have the septae. So which look is affected here?
Septa.
Septae. You're right. So it is in the septae. The pathology appears to be in the septae. Okay.
Yes, ma'am.
So what has happened to the septae? Let's go higher. What has happened to the septae? Are they normally this thick?
Thickened.
No, ma'am.
Thickened
No, isn't it? So the septae are thickened. They are widened and thickened due to what?
Inflammation.
Due to what? What is here in the septae?
Ma'am,
Are you
because of
seeing any infiltrate?
yeah, ma'am.
Infiltration.
Yes, there is a inflammatory infiltrate. What
Infiltrated because of fibrosis lipid, ma'am. Because of the that
Sorry,
yeah.
I didn't get you.
Widening of septum, ma'am, because of fibrosis and macrophages, ma'am.
So there are, okay. So you said there are lymphocytes and there are macrophages. We'll come to the macrophages a little later. The macrophages are not in the septate.
Okay, ma'am. Okay, ma'am.
So
Okay,
it's
ma'am.
mostly lymphocytes.
Okay,
There is
ma'am.
some edema here. There's
Yes,
septal
ma'am.
widening because of edema. And
Okay,
over
ma'am.
here, there is some fibrosis. There's some
Yes, ma'am.
fibrosis, right?
Yes, ma'am.
Okay.
Yes,
Anything
ma'am.
else? There are two fragments. Let's look at both the fragments. Anything else did you look for? I thought there were some occasional multinucleate giant cells that were
Giant
there,
cells.
isn't it?
Yes.
Did you see
Ma'am.
well-formed granulomas?
Ma'am?
Like the ones you saw earlier?
Yes,
There were
ma'am.
multinucleate giant cells.
Giants.
Yes,
And
ma'am.
if
Yes,
you
ma'am.
see, there are also some blood vessels along the septae. You see these few dilated vessels here along the
Yes,
septae?
ma'am. Yes, ma'am.
Okay. And here, what kind of a pattern is this? Is this septal or lobular? This looks lobular, right?
Globular
The middle of
pattern.
the lobules is
Lobular pattern, ma'am.
Yes, the fat spaces are obliterated and it looks like there is some amount of fat necrosis here, right? You're seeing this membranous change. You're seeing this
Yes, ma'am.
infiltrate, this dense lymphocytic infiltrate in between. And you're also seeing blood vessels which are thrombosed, right?
Yes, ma'am.
Thrombosed
Yes, ma'am.
vessels. So it is predominantly septal. There's a little bit of lobular involvement, right? So what would you want to call this? Together with the history. It's a paniculitis, right? What kind of
Paniculitis, ma'am.
septal or lobular?
Paniculitis, ma'am. Paniculitis.
Yes, you are right. It's paniculitis. Is it
Yes,
predominantly
ma'am.
septal or predominantly lobular?
Septal.
It's predominantly
Predominantly
septal,
septal.
isn't it? So why do we use this word predominantly? Why don't we say just septal and lobular? See, this is not a watertight compartment, right? So this shows you that even erythema nodosum, a so-called classical septal paniculitis, can have lobular involvement sometimes, okay? And what is typically described under lobular paniculitis can also show septal changes. So these are like, you know, the textbooks don't, I mean, they don't read. So it's we who make up the books and the criteria, right? So there's quite a bit of overlap. So what you're seeing here is a predominantly septal paniculitis. And the other feature that you're not seeing here, of course, is granulomas. You're only seeing occasional giant cells, but sometimes you may see well-formed granulomas, and I mean epithelioid granulomas. Now, that does not mean that you have to jump and do stains for tuberculosis, right? So, granulomas is quite common in any form of paniculitis. That is not a clue towards the etiology. And I'm going to skip this Misch's radial granuloma, which is given in the textbooks, because that's where it should be. In practice, we don't see it at all, because very often what happens is that the lesions are biopsied quite late and all we see is a vascular proliferation in the periphery of the lobules. It's something akin to granulation tissue that we see. So we don't see the typical features in the late lesion, and clinically also it appears just like a bruise. So the lesions would have even flattened out by then. Okay. So that is erythema nodosum, and this is the differential of predominantly. And one thing we need to remember is that paniculitis and vasculitis are like twins. So whenever you have paniculitis, you also have to look for presence of vasculitis. So these are the differentials for predominantly septal paniculitis without vasculitis. One is erythema nodosum, necrobiosis lipoidica, and we must remember that morphia also can go to the subcutis. Now I'm going to show you another case which I have not shared this slide with you all, but I'm going to show you this just to illustrate the difference. Okay, Now, where is the infiltrate in this case? Is it in the lobules or is it in the septum?
Lobules.
The lobules.
Lobules.
This is in the lobules, right?
Lobules.
This is a lobular panniculitis. And what is the infiltrate predominantly made of?
Lymphocytes.
Taking you higher.
Lymphocytes.
Lymphocytes.
So they are mostly lymphocytes, right? So this is a lymphocytic lobular panniculitis. And do you know which disease produces this pattern of lymphocytic lobular panniculitis? There you go. You have the clue here. The clue is in between the collagen. Even the audience can try. I'm going to show you the whole thing. So the epidermis looks relatively okay, but the clue is in between the collagen fibers. What are you seeing? This blue material. We saw it somewhere else earlier.
Mucin.
That's mucin. You see abundant dermal interstitial mucin coupled with this lymphocytic lobular panniculitis. This is lupus panniculitis or lupus profundus. Okay? So that is lupus profundus. Now going to lobular panniculitis. Now here there is a role for special stains. I'm going to ignore the one with vasculitis. I'm going to talk about the one which we see as predominantly lobular panniculitis. Now here the nature of the infiltrate becomes important. Is it predominantly lymphocytic or is it predominantly neutrophilic or suppurative? Now, if you see a predominantly neutrophilic, suppurative kind of an inflammation, what would you do? Definitely that's an indication for you to do your fungal or acid-fast stains and also cultures, right? So when you see a neutrophilic lobular panniculitis, always think and rule out an infectious cause, and even your fight stain could be done because we know that erythema nodosum leprosum, the panniculitis, they can present de novo. Now, lymphocytic lobular lupus panniculitis, there is an overlap with SPTCL, but in the interest of time, I'm not going to make that to get into that differential. Then you could have crystals as you see in subcutaneous fat necrosis of newborn. And you could also see this condition which is known as lipodermatosclerosis or atrophic panniculitis, which is seen in late stages of stasis. Okay, so these are the differentials for your lobular panniculitis. Now we'll move to case number 14. So this is 33-year-old female complains of hyperpigmented plaques over the abdomen and flank, and skin over the lesions is not pinchable. So Tina, would you like to take this?
Sections from skin shows a rectangular biopsy. Epidermis appears normal and dermis appears sclerotic.
I am not able to hear you, sorry.
Ma'am, section from skin shows a rectangular biopsy. Epidermis appears normal and dermis shows sclerosis and mild perivascular inflammation.
Okay.
Subcutaneous fat is normal.
Okay, the epidermis looks relatively okay, normal. Yeah. What else? What is striking you about this biopsy?
Shape of the biopsy, even rectangular shape instead of.
Very good, excellent. It's rectangular in shape. What else? Are you seeing adnexae? Are you seeing any adnexal structures? No, right? You're not seeing any adnexal structures. And what else? What has happened to the collagen?
Thickened collagen is thickened.
Yeah, it's thickened. It's hypereosinophilic. But the spaces in between them are still maintained.
Sclerotic.
Isn't it? Yeah, they're decreased, but they're still preserved. They've not merged with each other. And what is this? What do you call this? It's like a straight line. This is called as the line sign. You don't see it very often. So this is the line sign, right? So what are we dealing with? What is this condition?
Morphia.
Morphia, ma'am.
Morpheus scleroderma.
What is it?
Scleroderma.
Yeah, so there is a
Scleroderma.
scleroderma. So scleroderma is a generic term which tells you that it is hardening of the skin. So morphea, scleroderma, systemic sclerosis. So these are distinguished based upon the clinical features. Okay. The important thing is that sometimes you have an inflammatory stage in a scleroderma, right? So you can get perineural infiltrates too, right? That doesn't mean it's leprosy, right? You can get perineural infiltrates in a scleroderma. You can get a lot of plasma cells. And again, it depends on what stage of the lesion is getting biopsied. And if it's a late stage, you don't see adnexae at all. Otherwise, you do see adnexae which are pulled up, right? Which are at the mid dermis level. And like you rightly pointed out, the square shape of the biopsy to the naked eye gives away the diagnosis, right? Now, coming to differential diagnosis of fibrosing dermatitis, we should know the difference between fibrosis and sclerosis. What is the difference? Can someone tell me? What is sclerosis and what's fibrosis? So what we saw now, was it sclerosis or fibrosis? Although I know we use the term scleroderma. So in sclerosis, what happens is that the spaces between the collagen bundles is obliterated. So everything looks like a pink homogeneous mass. So the prototype of a sclerosing disease is lichen sclerosis. And sometimes you also see it in radiation dermatitis, right? Otherwise, we call it as fibrosis. And what happens in fibrosis? Either you see a lot of fibrocytes, you see a lot of cellularity as you would see in a scar or a keloid, or sometimes you don't see so many cells, right? You could see histiocytes and fibrocytes as you see in later lesions of a dermatofibroma or a xanthogranuloma, right? So this is the differential diagnosis for fibrosing dermatitis. I request the chairpersons to give their comments for both the paniculitis and the fibrosing dermatitis lesions.
Just a brief comment about the erythema nodosum. Sometimes it is not always nodules, like it may be a plaque on the legs or even at other areas when it is the migrans variant. Histopathology is the same. And as far as the scleroderma case is concerned, localized scleroderma or morphea is much more common as compared to systemic sclerosis. So, and frequently, like both the conditions, systemic as well as localized scleroderma, tend to get biopsied in the atrophic phase when the patient, because the condition is asymptomatic. So they present late in the disease, and so it ends up being in the atrophic phase. So you may not see the classical boxing of the dermis every time. Thank you.
Yeah, sometimes this scleroderma is alarming if patient is complaining of a tightening of the skin along with the joint pain, and that is exaggerated response to the cold, especially that is the Lennard's disease, and sometimes complain the heartburn. So that is those are the alarming signs of if patient is suffering from scleroderma and we are giving the diagnosis of scleroderma process. Just want to include in this.
Sorry, I'm not able to hear. I don't know if it's a problem at my end.
Okay, I just
able to hear you. I think we can go to the next case.
Okay, we'll go to the next case. This is the last case for today. It's a 42-year-old man with multiple hypopigmented scaly patches over the trunk and buttocks since 3 years. And he says that some of them have increased in size. Who would want to take this case? Tina? Tina, you can start describing the case.
Section from skin shows normal epidermis, and superficial epidermis shows mild band-like infiltrate
Okay.
composed with lymphocytes.
So there is a lichenoid infiltrate, you're saying. Okay. Yeah.
Yes.
Okay. What else?
There is some perivascular inflammation.
Can you be clear? I'm sorry, I'm not able to hear you.
Some perivascular inflammation.
Okay, you said there's also a perivascular infiltrate. Okay, here it's lichenoid and okay, it's a little bit perivascular. What else? What about the epidermis? What's happened to the epidermis? What are you seeing here? I'm pointing to something. What are these cells? There are so many of them in the epidermis, isn't it?
Epidermotrophism.
What cells are those?
Neutrophils.
Neutrophils, are they neutrophils? Look at the nucleus, they are not lobe, right?
Lymphocytes.
These are lymphocytes. So you have a lot of lymphocytes in the epidermis. Is there any particular pattern to their arrangement? So far you've seen lymphocytes in the epidermis, isn't it? In what situations did you see them? You saw them in spongiosis, you saw them in interface dermatitis, right? Okay. So are you seeing any of those changes here? Are you seeing spongiosis? Are you seeing interface changes? I'm showing you the entire breadth of the epidermis.
Yes, ma'am.
You're seeing lymphocytes, but are you seeing spongiosis and interface dermatitis?
Yes, ma'am.
Are you seeing them? Really?
Minimal. No.
Are you seeing basal vacuolar alteration? Are you seeing necrotic keratinocytes? Are you seeing intercellular edema? No, right? You're not seeing any of those changes. But what are you seeing? You're seeing a lot of lymphocytes. And is there any pattern in which they're arranged? See, I'm pointing to this. There's something here. There is something here. It looks like it's delineating or arranged along something. Of course, there are a few clusters on top at the higher level in the stratum spinosum, but predominantly how are they arranged? They are arranged along the basal layer, right? So they are like toy soldiers which are aligned along the basal layer. So what is this feature called? It is called basilar tagging or basilar epidermotropism. And what are you seeing here? Is this a spongiotic vesicle? Is this a pustule? Is this an abscess?
Microabscess.
What do you call this? This is a cluster of lymphocytes, which is often referred to as a Poitier's abscess or a Pierre's microabscess, right? So you have so many lymphocytes which are peppering the entire epidermis. You don't have significant changes in the stratum corneum. You have these basilar epidermotropism. And even in the dermis, you have only lymphocytes, right? You don't have any other cells. Can we look a little bit at the hair follicle here?
Yes,
do you notice anything here? Do you notice that these lymphocytes are also peppering the hair follicle?
Yes, ma'am.
Yes,
ma'am.
The same thing, the basilar epidermotropism, there is also folliculotropism here. You see that?
Yes.
Yes.
And there is no basal vacuolar alteration. There's nothing else. It's as if the epidermis is absolutely not bothered by these cells which are coming. So what do you call this? This is called disproportionate epidermotropism. Disproportionate to what? Disproportionate to the amount of spongiosis, right?
Yes,
so that is what is called as disproportionate epidermotropism. In fact, it's not just epidermotropism, it is epitheliotropism. So what would you suspect in this case? Does the history favor a diagnosis? That's the most important question that you need to ask in this case. So this is a lesion which is long-standing, which is on non-sun exposed sites. present for 3 years with a history of increase. So combining all these features together, I would favor a diagnosis of a
Mycosis fungoides.
hypopigmented mycosis fungoides or a path stage mycosis fungoides, right?
Yes, ma'am.
So there are, so this is a mimic of an inflammatory disease. So it masquerades as an inflammatory disease. It can be very difficult to diagnose on an initial biopsy in an early lesion. So there are different epidermal patterns that you see. What are the patterns? If you see a lichenoid pattern, a spongiotic and lichenoid pattern, if you see a psoriasiform and a lichenoid pattern, or if you see a spongiotic, psoriasiform and lichenoid pattern, and a psoriasiform nodular pattern with a dense dermal infiltrate of lymphocytes, think of MF. Think of it, but don't confirm it unless the clinician is also on board with the diagnosis. And these are the various features of MF that you could see on scanning magnification. Changes of parakeratosis, disproportionate and basilar epidermotropism, haloid lymphocytes. So there are clear spaces around the lymphocytes. Pagetoid spread, which means that they could go up, even up to the stratum granulosum. Epitheliotropism. Sometimes the dermal papillae are just stuffed with lymphocytes. They are so chock-a-block with lymphocytes. You don't see the papillae at all. Wiry dermal collagen. I'm sorry, I forgot to show you that feature. Let's go back and look at it. So if you look at normally, the papillary dermal collagen is very thin and delicate. But if you look at it here, it's quite thick. You see this? This is referred to as the wiry collagen. You know, think of that wire loop lesion which you see in lupus nephritis. This is something like that. So this is the wiry dermal collagen, which tells you that the infiltrate has been there for a long time and absent dermal edema. So these are all the features favoring mycosis fungoides. But remember, however bad the infiltrate may look histologically, don't sign it out as MF if the clinical features do not fit, right? That's the most important question that you need to ask. If you're not sure, if you are certain on histology, but clinically it does not fit, just wait and watch. You could sign out something like this, that look, I'm looking at an epidermotropic lymphoid infiltrate. And remember, it is not always necessary to see atypia in the lymphocytes, right? You need not see them. Atypia can come only in advanced disease. In path stage lesions, you don't find atypia at all. So you could, this is just a sample. You could say, we don't know the significance. It requires follow-up. If it doesn't resolve, always consider repeating a biopsy, right? So that was actually a non-inflammatory lesion, which masquerades as an inflammatory lesion. So I think with that,